Good day, guys. My name is Chase Besantwit. I'm a medical doctor. Currently, just wanted to teach you or discuss rather a topic, namely hyperprolactinemia, which is a medical condition where there's excess secretion of prolactin, a hormone produced by the anterior pituitary gland of the brain. So, hyperprolactinemia is a condition, as I said, excess secretion of prolactin in a physiological state or due to violation of mechanisms regulating prolactin secretion. What is prolactin? So, prolactin, as I said, is produced by the pituitary gland. It is a single amino acid polypeptide which is used for the secreted by lectotrophic cells of the anterior pituitary gland. Its half-life is about 20 to 30 minutes, and dopamine, which is a precursor hormone on its own, is responsible for regulating prolactin secretion. With inhibitory control as well, and this acts on the lectotroph D2 receptors. So prolactin has various functions. It increases during the menstrual cycle, whereby there's significantly high luteinizing hormone surge that rises further during the luteal phase in pregnancy. Lactation then has to occur that empties the breast, whereby milk production takes place and prolactin is then released. It decreases gradually during menopausal periods as well. The various organs with prolactin receptors, namely the ovaries, uterus, placenta, the liver, adrenal glands, pancreas, just to name a few. Its functions in women is to regulate the volume and composition of amniotic fluid. It prepares the mammary glands for lactation, as I've mentioned before. As well as it synchronizes follicle maturation and ovulation with luteinizing hormone. It then mainly is responsible for stimulating milk productions in the alveoli of the mammary gland. Hyperprolactinemia is a quite vast condition which is diagnosed in about 17 out of 1,000 people in both sexes, male and female. So it's not only occurrent or predominant in females. There are various classifications which can be divided into functional, organic, and iatrogenic, and then rare forms, which is relevant, then symptomatic, as well as a transient form of prolactin increase, which is mainly occurrent at night. So for physiological prolactinemia, it usually peaks during pregnancy and is maximal in childbirth. So it also occurs in early nursing, whereby we have lactation, as I've mentioned before. During sleep, after about 60 to 90 minutes, it occurs, there's a droppage of 3 to 4 hours then after you wake up. It increases with food intake as well, yes, and sexual intercourse, as well as I mentioned, follicular phase of the menstrual cycle. The other causes as well, which are drug related, namely the use of contraceptive pills, antipsychotic drugs such as hallucinogens, gastrointestinal motility medications like metoclopramide. It also causes an increase in prolactin hormone as it is, and then as well as antihypertensive medications like verapamil, methyl-dopa, just to name a few. Then other causes then are prolactinomas, which are basically tumors within the anterior pituitary gland that increases the surge of the hormone as there are multiple cells of lactophores produced. Then also increases then the production of prolactin hormone. So the clinical picture would be during menstrual cycle we'll have menstrual disorders such as oligomenorrhea, meaning basically there's a very low bleeding during the menstrual cycle of females. It can also cause anovulatory infertility, galactorrhea, which is an overproduction of milk, headaches, simple is a clinical presentation such as fatigue, weakness, mental retardation or slow reactions, or rather of the mental state, and as well as decreased libido, as well as visual disturbances. So how is it diagnosed? During pregnancy, your GP will then work you up, basically, as we say, for hyperprolactinemia. So we look at things like lactation, how frequent it takes place, and then symptoms of it, which is then the galactorrhea as well. Medication use, as I've mentioned before, drugs such as your antipsychotics, if you're on gastrointestinal drugs such as metoclopramide, just to name a few. And then if a patient then has kidney and liver diseases, prolactin stimulation can also occur. So he will do then various tests as they do take your blood first and then go through your blood serum, which is taken then around 9 to 12 a.m., which then would constitute the highest production of prolactin. And then they will, or the medical doctor will then determine the level of follicular stimulating hormone, the luteinizing hormone, estradiol as well, and then testosterone as well. If there's minor hyperprolactinemia is detected, it is better than that they do repeat the test again. We can also do then ultrasound imaging, or rather studies, investigations. Will have a reduced size of the uterus and the ovaries. We will also note then polycystic changes in the ovary as well, and these are clinically also assessed in conjunction with the images that are studied. How do we go about the imaging modalities of the pituitary gland? So a CT brain will be done, whereby your doctor will note that there is an increased size in the pituitary gland. This could be then a sign of a pituitary adenoma, which is then a cancer, or sorry, a tumor that is formed on the pituitary gland. A plain X-ray could show then an increased size in your sella tutsica. Then also an MRI study which can be done to see whether there is a better imaging view of macroadenomas, which will then appear as a iso-intense on T1 imaging scale, and will be enhanced uniformly with a solution called gadolinium. So how do we treat this condition? So for overproduction and stimulation of this, we use a drug called bromocriptine, which is also known as Parlodel. About 2.5 to 7.5 milligrams a day can be taken with meals, which is good for functional hyperprolactinemia. Also, carbogoline, um, which can be taken once or twice in the week, which is indicated in prolactinomas, which is, as I have mentioned, an increase in the prolactin, pituitary gland organ. So, management of this, we have various groups which we can classify as 1, 2, and 3. There are idiopathic microadenomas associated with hyperprolactinemia. These cases can be managed medically alone. Group 2, where there is a hyperprolactinemia with macroadenoma. This group needs fertility management as well as a combination of drugs, surgery, and then radiotherapy. Group 3 then is the Melissen's group, which involves hyperprolactinemia due to systemic disorders, drugs, pituitary hypersecretions, and hypothalamic pituitary stalk damage in the brain. This is treated by focusing more on the underlying etiology. Yes. Prolactinomas can be surgically and, as I said, with radiation and drugs, it can be treated. These methods can be combined and are quite useful. All patients with identified macroadenomas should be observed by an endocrinologist, of course, and then consult neurologists as well. That should be it for today's lecture on hyperprolactinemia. Thank you for joining me, and just keep an eye out for our next videos on endocrinological conditions. Thank you.